Hey everybody, my name is Paul Jhun and this is John Mabee.
Hi there.
And we are here to answer some of your questions from the Hippo Mailbag. And today we actually have a question from the Hippo EM Board review site, so let's get started.
All right. Let's address a question presented by Elizabeth. What is the pathophysiology of metformin and contrast-mediated renal failure, and how long do you hold metformin before resuming?
That's a great question. So to answer that question, we should set a little context first. So metformin actually has a black box warning for developing lactic acidosis.
Right. Now, isn't there some controversy, though, about the black box warning?
Yeah, it's quite controversial. When you look at the literature, toxicology literature shows us that, yes, there is lactic acidosis that can result from metformin overdose. But when you look at, for instance, a Cochrane large meta-analysis of 70,000 plus patient years,
huge.
Yeah, in the use of daily, just normal use of metformin, there is no cases of lactic acidosis. Really, in the published literature, those cases of lactic acidosis in metformin are in sick patients who are hypoperfused or septic shock and stuff like that. So very controversial. That being said, there is a concern when you have IV contrast for radiological studies like CT scans that we use nowadays a lot of, and how IV contrast has been associated with contrast-induced nephropathy.
So can you remind me on that contrast-induced nephropathy?
So contrast-induced nephropathy, really, the technical definition is if you have a 0.5 mg per deciliter bump in your baseline creatinine or a 25% increase from your baseline. But really a defining feature for CIN or contrast-induced nephropathy is that your renal function returns to baseline after a few days. And so the theoretical concern is, let's say you have a bump in your renal function, although it's not clinical-oriented outcome, it's just a number. If there's a bump in it, the theoretical concern is that you won't be able to clear the lactate as well, and that you might exacerbate or induce that metformin-induced lactic acidosis, worsening it. And so that's what the concern is.
So what are the guidelines then?
So the American College of Radiology, they actually published a guideline recommendation saying that you should hold metformin for 48 hours after receiving IV contrast in otherwise healthy patients with normal renal baseline function. But really, it's not evidence-based. Like good quality evidence-based, it's more of expert consensus.
So you mentioned evidence. What is the evidence?
Well, when you look at all the different society guidelines, it's all over the place. But that being said, there was a great article in 2010 by Gorgon who reviewed all the evidence that existed and basically found that there was no good quality evidence. Really, this is what their conclusion was, and I think it's worth listening to, which is, at present, there is no evidence to support guideline recommendations to stop metformin administration or even to retest renal function after contrast medium administration in patients with normal baseline renal function who have received a moderate contrast medium load, things that you would find in a typical acquisition of a single CT scan. And really, the ACR guideline recommendations, they even say, which is kind of crazy, in patients with abnormal renal function at baseline, that you should actually hold metformin until you recheck their renal function again after a few days. And you should not restart metformin until it returns back to baseline, which is really, really inconvenient.
Yeah, absolutely.
And so, in summary, the whole theory behind it is you have IV contrast, CIN, and you should hold the metformin according to ACR for 48 hours because CIN will normally resolve back to baseline within a few days. So that's the answer to your question. Thanks so much, Elizabeth.
Great.
Otherwise, that's it for this segment of Hippo Mailbag. We'll see you next time when we answer more of your questions.
All right.